Diseases. As director of the Wellcome Trust, he founded the Coalition for Epidemic Preparedness Innovations, which is coordinating global efforts to produce a coronavirus vaccine. He's the man in charge. He's also a member of the key SAGE committee, which advises the government on the pandemic. And I spoke to him earlier this morning and started by asking, are we heading towards the worst death rates in Europe?
Yeah, it is possible. The numbers in the UK have continued to go up. I do hope that we're coming close to the number of new infections reducing, and in a week or two, the number of people needing hospital reducing, and tragically, in a couple of weeks' time, the number of deaths plateauing and then starting to come down. But yes, the UK is likely to be certainly one of the worst, if not the worst affected country in Europe.
So my next obvious question, I suppose, is why? Because I know you advise the German government as well, and they have done far, far better. In your view, why is that?
Germany had, early on, a number of people came back from holidays in Italy, and also there was an individual that travelled from China very early in the epidemic in Germany. And Germany, very early on, introduced testing at a scale that was remarkable, and has continued to do that, and then isolate individuals and look after those that were who got very sick, and as a result, they were able to know exactly what was happening with the epidemic in Germany, but also were able to isolate those that were positive, mean that they couldn't then transmit it to other people. And I think that has played a key role in Germany at the moment, being able to keep the numbers of people hospitalized and the number of people tragically dying at a low level. It is still early in this epidemic, though, and what is critical for Germany is that they continue that testing and isolation, and inevitably the UK will learn lessons from how Germany has managed to control the epidemic to date.
So it seems fairly obvious that we didn't follow the WHO's advice early enough and test, go and hunt down the virus. Was that mainly because we didn't have the kit?
Well, every country has struggled with the kits. I also chair the Research and Development Advisory Group at WHO, so I've been very involved in the advice at WHO. And testing has been a critical component of this, and testing allows you to identify those at risk, isolate them. It means that they can be well looked after, but it also means they won't transmit it to other people. And testing also buys you time, critically. Testing in the community buys you time in order to make sure that you've got the hospital capacity to deal with probably an inevitable surge when it comes in demand on hospital services. It allows you to make sure that healthcare workers are protected with personal protective equipment. And it allows you that critical 6 to 8 weeks in this pandemic that you can really make sure your systems, health systems and other are working to the very best capacity so that you can look after the maximum number of people. And undoubtedly there are lessons to learn from that, yes.
Can I ask you a little bit about what we're learning about the virus itself? Because there are worrying suggestions coming out of Korea at the moment that people having been infected can be reinfected, or that it can be dormant and return again later.
Yeah, we're learning so much about this virus. We should just perhaps remind ourselves we're about 100 days now into the emergence of a completely new human virus. None of us have seen this virus before. None of us have developed any immunity, and we don't know yet how that, after being infected, how long and to what extent any of us have immunity and how long that will last. And the reports from Korea, I think there's been almost 100 reports now of people that have been infected, they seem to have recovered, and then at a later date they became infected again. It is critical to understand whether those are one viral infection that has persisted in one individual for a considerable time and now has reactivated, or whether they've been infected with a second virus. Either way, it suggests that perhaps immunity in some people is not complete, and that has major ramifications for the ability to make a vaccine and also for the community to be protected against future waves.
Another issue a lot of people are talking about is whether different groups are more vulnerable to it. Putting aside the kind of social and political sides of this, is there any evidence at all that members of some ethnic minorities might be more vulnerable to COVID-19 than the rest of us?
Yeah, there is some evidence growing, both actually in the United States and here in Europe, that people from BAME backgrounds are more at risk. What is critical to work out is that something specific to that background, or is it related to other risk factors that we know about, age, other illnesses that people have, diabetes, people that are obese have been more affected, people with high blood pressure, people with heart disease, lung disease. And it's critically important we understand which elements of that are the real risk factors, because that will enable us to both identify those people that perhaps are more vulnerable, perhaps at more risk, and therefore we can try and shield them, isolate them, and make sure, if at all possible, they don't get infected. But if they then do get infected, to make sure that we can get treatment to them as early as possible to save lives.
The Oxford University group that have been working on this now say that there's an 80% chance of having a usable vaccine ready by September. Without going into percentages, does that sound remotely plausible? I know that you're looking at all the different vaccine trials going on around the place.
Yeah, it's my view that treatment and vaccines are really our only true exit strategy from this. We're determined that we do all we can today to save lives, but we're also determined that we don't go through this ever again. And I think the chances of second and third waves of this epidemic are probably inevitable. And therefore, having the right treatments to save lives, but also having a vaccine in the future is going to be absolutely critical to prevent those second and third waves. The Oxford group have been working incredibly hard for many years. They've developed vaccines against a number of different illnesses, from malaria. They're working on tuberculosis. They're working on MERS, the Middle East virus that's actually similar to COVID-19. And I think there is a very good chance that they will be able to produce a vaccine that can start to be tested in the summer, and we would know by the autumn of this year whether that vaccine was inducing immune responses in people, and we hope would be protective. But that is the start. And although Professor Sarah Gilbert is absolutely fantastic in what she says, she would also be the first to say we then need to make sure we can manufacture it at scale, we can deliver it to everybody that needs it, and that would be a very large number of people globally, billions of people, and that we then need to be able to both manufacture and distribute and make sure it gets to everybody that needs it in a way that is accessible and affordable to them and available.
What's your likeliest option as to when people will actually be able to get a vaccine?
Well, if we just think that through, that vaccine will be going into volunteer studies in the summer, so May, June, July. The results will be available in September, and then there'll be a push in September to give it to more people and see is it not just safe, but is it also effective. In parallel with that, and going on through the same time frame, the manufacturing capacity has to be built, or manufacturing has to be available somewhere. We cannot take from other vaccines that are being developed. If we took over the vaccines that are producing measles vaccines around the world or other vaccines, we would face epidemics of those diseases. And as Gavi, the Global Alliance for Vaccines, has very clearly said, if we do that, we will face more deaths from other diseases. So this is going to have to be done in a completely different way. I absolutely agree with Sarah Gilbert that the vaccine, I think, will be available during the autumn of this year, but that will not be at the scale that's required to vaccinate maybe many billions of people around the world. And it's that alignment of everything, from the science through the manufacturing, through the distribution, that in its totality to vaccinate billions of people around the world. I would hope we would get done in 12 months. But that is in itself an unprecedented ambition.
A final question, Sir Jeremy. As recently as the middle of March, the expert group looking at this kept the threat level at moderate and told ministers it was a moderate threat level. With hindsight, a wonderful thing I know, with hindsight, that was surely a mistake.
Yeah, I think from the end of January, certainly into February, I think there was very clear indications from China of human-to-human transmission, that yes, although this was focused on Wuhan, there were other cases beyond Wuhan, and indeed there were other cases in the rest of the region becoming obvious. And I think from the early days of February, certainly, if not late January, it was obvious that this infection was going to be very serious. and that it was going to affect more than just the region of Asia where it started. So yes, in hindsight, actually at the time, I think it was clear that this was going to be a global phenomenon. I don't think anybody could have predicted the pace of it or the speed of it. None of us could have predicted that. But many of us that lived through SARS and bird flu and many other epidemics of the last 20 years, I think it was very clear this was going to be an unprecedented event.
Sir Jeremy Farrar, thanks very much indeed for talking to us this morning.